Hi. So we're going to talk about cataract. Cataract is basically opacity in the lens. It could be a small, it could be a large opacity. It's one of the most common cause of blindness in India, and we've seen it mostly in our senile age group people. Before we get into cataract, let me just talk about a little bit of the basic lens anatomy. This is the suspensory ligaments that we have out here. This is the suspensory ligament. We also have this anterior capsule that is the posterior capsule and the anterior capsule. This is the anterior capsule. This is the posterior capsule. This is obviously the cornea, and inside we are going to have lens fibers that are going to come from the nucleus. So let's say this is the nucleus, and they have fibers that are radiating. Okay, so you can have different nuclei. You could have your embryonic nuclei, infantile nuclei. Okay, all of these nuclei that are present in the lens. Now, if the opacity involves the nuclear region, it's called a nuclear cataract. It involves the cortex region, it's called a cortical cataract. If it involves the posterior capsule, or if it involves somewhere around the region of the capsule, it's a subcapsular cataract. So similarly, around based on the location, we can differentiate between the types of cataract, obviously, but we won't differentiate based on the types of cataract. We will try and differentiate based on uh, the causes, okay, of cataract. So let's directly jump into the causes. First of all, we need to understand that the symptoms of a cataract, the clinical features of a cataract, are going to be very much common for all of them, because in the end there's just going to be an opacity, and the only difference is going to be where the opacity is going to be present. So there's going to be loss of vision depending upon the size of the cataract. If it's a big cataract, obviously smaller is the vision that is retained, and in a larger cataract, obviously more is the blindness, and in a smaller cataract the blindness is less relatively. Obviously there's going to be a lot of changes of refractive index. Okay, so because of that there's going to be change in power, because in cases of cataract there's going to be opacification, and because of that there can be also changes of the refractive index, and because of it, there's obviously change in power. There's obviously something called as a unilocular polyopia, basically because in one of these eyes, let's say one of the eye has a cataract, and because of cataract there's going to be a lot of dispersion, and because of that there's going to be different images that could be formed. All right, also you could see a lot of halos is again is one of the causes which can cause polyopia. So halos occurs because of the diffraction of light rays. All right, if there's a cataract and there is light rays coming, obviously they're going to be diffracted. Okay, they're going to be diffracted, and you could have a lot of images. So basically diffraction of light rays and splitting of them into different bandwidths, obviously your bandwidth. So it can lead to halos, obviously, and the halos can be differentiated by using something called as a Fincham test. Fincham test uses a stenopic slit. A stenopic slit is basically put in front of your eye. So let's say it's going to actually cut the light ray, and when the halos are intact, it is usually a cause of PACG, that is a primary angle closure glaucoma. Primary angle closure glaucoma is another cause of halos, and the other cause of halos is cataract. And when you do a stenopic Fincham test, your halos are usually broken, and that is why that's how you can differentiate a halo because of cataract or a glaucoma. The other disease where your halo is seen is obviously your conjunctivitis. But when you wash the halo is gone. So that is a very important finding. Also very important, now we will get into the differentiation of cataract, because we've actually seen that the major symptoms, okay, it's polyopia, loss of vision, glare, obviously halos and glares. So I do not really want to linger much upon the clinical features because it's very generalized. So let's directly go into the causes of cataract. And the causes of cataract, the first that should hit you is the acquired causes. And in acquired causes we have diabetes mellitus, galactosemia, muscle dystrophy, myotonic dystrophy, and Wilson disease. That's very important. So let's look at diabetes mellitus. What happens in diabetes mellitus is that there is increased glucose can lead to increased sorbitol, and increased sorbitol can lead to something called as a snowflake cataract. Okay, something called as a snowflake cataract. Let me just write it in a better format. All right, your diabetes mellitus can lead to snowflake cataract. What is snowflake cataract? That's just an important MCQ. It can lead to a snowflake cataract. It's a subcapsular, it's a cortical cataract, sorry, and it could be a subcapsular cataract again. So the cortex area is usually affected. The cortex of the lens is affected. It could be anterior, it could be posterior, and that's a very important point. It's a pre-senile cataract. Actually, it's seen in the age group, the older age group, and there's obviously a lot of refracting errors. Because of the refracting errors, there's going to be intraday fluctuation. There's a lot of fluctuation fluctuation of Ri, and because of the fluctuation of the refractive index, what actually can occur is that you sometimes can see better, you can sometimes see worse. So that's very important. Why this occurs? Because of the difference in glucose level throughout the day, and when there's more glucose, there's more swelling of the lenses and lesser vision. And as the glucose level decreases and as the insulin peaks, the swelling of the lens decreases and your vision obviously retains itself again. A very important disease that we have now is galactosemia. Galactosemia I like to remember as an oil drop cataract, as an oil drop cataract, as an oil drop cataract. Alright, as an oil drop cataract, an oil drop cataract is seen, and it's a subcapsular cataract. It's a subcapsular posterior cataract. So posterior subcapsular cataract, as I've said, it's a subcapsular. That means it's under the capsule. Obviously, it involves the cortex, and it's a reversible cataract. That's very important to note that it's a reversible cataract. Second to say is that galactosemia is differentiated on what are the causes of galactosemia. Alright, if there's a galactose kinase deficiency, it's only a cataract. But let's say if there's a UDP1 UDP galactose epimerase, or let's say galactose 1 phosphouracil transferase, one of the GALT enzymes, so you could definitely have mental retardation, hepatomegaly, and also cataract. What you want to do is that you could directly measure the amount of glucose in the urine. So you need to do a Benedict test to check for galactose in the urine. A very important thing is that where else can you actually think of an oil drop feature when it comes to the ophthalmology? I think you could think of oil drop in one of the uveitis. All right. But I think we'll get into this a little later. Let's just finish other metabolic diseases like myotonic dystrophy. Myotonic dystrophy, I put it as green because it causes a Christmas tree cataract, and a Christmas tree cataract is again a posterior subcapsular cataract, just like galactosemia. It's again a presenile cataract, and because of myotonic dystrophy is basically there are two types. There are muscle dystrophies. We've got muscle dystrophies like a Duchenne Becker, and then we have something called as a myotonic dystrophy. Myotonic dystrophy is again a trinucleotide repeat, and the thing about myotonic dystrophy is that you have a lot of dystrophy. There's a lot of dystrophy that's occurring in your muscles. Okay, which is why. Which is why you could also see certain amount of ptosis, nystagmus, strabismus, and stellate cataract is also seen. Also, so instead of saying Christmas cataract, you'd also say stellate cataract. Stellate is another very important point in ophthalmology because it can lead to stellate precipitates. Stellate precipitates is again seen in uveitis, like Fuchs heterochromic uveitis, FHI, iridocyclitis, and also you can also think about stellate precipitates in something called as an hepatic uveitis. Alright, and then obviously we have your Wilson disease. Wilson disease is due to a deficiency of ATP7B7, ATP-B7 48 gene. Alright, now ATP-B7 48 gene is actually causing the excretion of copper into the bile ducts, and also addition of copper into the ceruloplasmin. So what actually occurs is that there's the increased level of copper in the serum, there's an increased level of ceruloplasmin, okay, and there's increased amount of copper in the liver. This is a very, very important gold standard test of doing liver biopsy and checking for copper levels. Okay, so you could do one of these tests and you could check for copper. And also obviously your very pathognomic feature is something called as a K-Fisher's ring. A K-Fisher's ring is something that we've seen. K-Fisher's ring is something that we've seen around the cornea. And see, there are three rings that you should remember. K-Fisher's ring, obviously your KF1 ring, KF ring. Also very important is arcus semilunaris, or something called as a gerontoxon. And very important to know is the pseudogerontoxon. Pseudogerontoxon is something seen as an vulnerable keratoconjunctivitis. Okay, VKH. Alright, so that is something very interesting that we have also seen. Apart from that, obviously it can also lead to sunflower cataract. A very important cause of cataract is Wilson, where it leads to sunflower cataract. Very, very important, and this is as rapid as I think this is. It's very important to understand as well. Also, it can also lead to hypercalcemia because of the Wilson, that can damage the PTH in certain cases. Also, there's a very important thing that I might have forgotten to mention is something called as a parathyroid, PTH, parathyroid associated cataract, which also causes anterior and posterior subcapsular cataract. Because why this occurs is because sometimes when you do a PTH tectomy, parathyroid tectomy, we do there is decrease in PTH, and decrease in PTH is going to cause a decrease in calcium levels, any cause of calcium levels. And I think we all know that hypocalcemia causes something called as groan moans, periodic overtones, and moans. So very important is that to remember that PTH deficiency can lead to hypocalcemia, and hypocalcemia can definitely can proceed to something called as an anterior and posterior subcapsular cataract. Very, very important. Then as I promised that we will look into traumatic cataract, let's talk about traumatic cataract. Traumatic cataract is basically any kind of trauma. So let's say if you have a blunt trauma, all right, let's say you have a blunt trauma, or you have a UV radiation associated trauma, you can have cataract. Blunt trauma, you could lead to a posterior subcapsular. A blunt trauma can lead to a posterior subcapsular rosette shaped cataract. All right, a rosette shaped cataract. You can think about that. You could think about infrared cataracts, rays that causes glass blower cataract, one of those. Lightning, yeah, very, very important. A very, very high yield point is that lightning, apart from it causing filigree burns, that's a FMT point, it also causes something called as an anterior capsular opacity. Very, very important. Very important. Anterior capsular opacity are not actually seen in a lot of condition, therefore I had to put it. Okay, complicated cataracts that I had already promised that we will look into. Complicated cataract is obviously a very important point to be noted, because of the fact that they are seen in a condition. They are usually the breadcrumb cataract. They are posterior capsular breadcrumb, and you want to remember that breadcrumb cataracts are usually posterior subcapsular cataract. They are obviously posterior subcapsular cataract. And where are they noticed? Actually, they are noticed in 3-4 conditions. Obviously, I want you to remember uveitis. Uveitis is one of the most common conditions. Also, you can think about angle closure glaucoma, which causes glaucoma flecken. If you want to know walk triad, there's something called as a walk triad. I'm not going to write it. You just remember that walk triad is a triad in acute angle closure glaucoma, where you see glaucoma flecken. You can see also certain amount of corneal haze, and also a little bit of if I'm not wrong, a little bit of stretching of the corneal epithelium as well. So one of those triads are something called as a walk triad, and it can also be seen in retinitis pigmentosa, and also in myopia you could see cataract. So these are the causes of cataracts when it comes to complicated cataracts. Complicated cataracts is a breadcrumb cataract. I'll get back onto the walk triad as well. I'll just give me a second. A walk triad, in my opinion, I think a walk triad is definitely the triad of 3 things. Okay, it's definitely the triad of 3 things that includes obviously a glaucoma flecken. It includes the iris atrophy. Oh yes, sorry. It includes your non reacting iris. So obviously there's going to be a lot of iris atrophy. There's going to be glaucoma flecken in walk triad. There's going to be pigment deposition of substances on the corneal epithelium, on the corneal endothelium, and that is basically glaucoma flecken. Apart from glaucoma flecken, we had to check another very important thing before we get into the senile. Correct. Before we get into the senile and senile, pre-senile, the other pre-senile cataracts that we spoke about is definitely diabetes mellitus and myotonic dystrophy. So those are the 2 things that we had to check also. And a very important thing that we had to check was your oil drop finding. Oil drop finding in cases of oil drop finding is usually a case of galactosemia, but oil drop finding when you check for any other disease, that is something that we were kind of looking at. And obviously oil red finding was certainly not found. I cannot remember about it recently, so I think we let this one pass about oil drop. I wish I could remember where it was. This is actually bad. One sec. Oil drop. Iridodialysis. No. No, 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 no. It's really sad how I can't remember where exactly did I see the oil drop sign. Uh, yes, I thought so. Yes, it is at the keratoglobus. Keratoconus, not globus, keratoconus, where the cornea is actually in a cone shaped. Obviously, you can see your oil drop reflex on your ophthalmoscopy, but obviously, it's not an oil drop cataract. That is the only thing that had come to my mind when I thought of oil drop. What does keratoconus actually have? Keratoconus is just a congenital where you have increased in the cone shaped, and you can actually see it associated with trauma. It can also be associated with VKC and trichiasis, also in Down syndrome. It could also be associated with Marfan or Lingdan loss, or it could be associated with retinitis pigmentosa, ectopia lentis, a lot of ocular conditions as well. So what actually occurs is that there's going to be astigmatism, there's going to be myopia, there's going to be increase in anterior chamber. Also, there's going to be Munson sign, where actually when you look down, there's going to be dipping of the lower eyelid. Also, there's going to be Rizuti sign, which is arrowhead on split line examination. Rizuti, and there's a very important is that retinoscopy. You see scissoring reflex, and you're going to see walk stria again. You do not need to get confused between walk stria and walked triad. Coming next to complicated cataract. Once we're done with complicated cataract, I think we should definitely jump into senile cataract, which is the most important. So let's directly jump into senile cataract. Let's talk about senile cataract really quick. Senile cataract can be of cortical and nuclear. Both of them have certain stages, obviously. So let's decide that we'll do nuclear first. Nuclear basically means it involves the nucleus first. All right, obviously. So because it involves the nucleus first, is about 860 years and it's a central opacity. So because it's a central opacity, obviously, I want you to understand that vision is going to be better during the day. Vision is going to be better during the night, obviously. Why? Because when it's during the day, you have got your iris is going to close because of meiosis, and when your iris is actually the constrictor pupillae, they contract and they cause meiosis. There's going to be positive rays through the center, and which is why the day vision is going to be bad during the day. Okay, during day. So that is nuclear cataract. And nuclear cataract, definitely you could use you could think about it that there is something called as the second vision in nuclear cataract. This is very important. We always say that sometimes they come and they be like, oh, you know what, actually my numbers are gone, and that is simply because the patient says that there's improvement in near vision, but patient is already a presbyopic. So basically what happens is that in a presbyopic patient, the near point recedes. All right, the near point recedes, and because of which, whenever there is a sclerosis, the refractive index increases, and obviously you do not need your glasses. That is one important point that has to be kept in mind. So a presbyopic patient comes with second vision. You need to keep myopia in mind. You need to keep nuclear cataract in mind. All right, there are 3 grades: 1, 2, 3, 4. First is yellow, second is amber, 3 is nucleus or cataract brunesca, and then you have nucleus nigra or cataract nigra. So yellow is obviously your urochrome pigment, and you will see a lot of xanthopsia, yellow colored vision. Xanthopsia is also seen with digoxin, just to keep that in mind also. Alright, digoxin toxicity, digoxin side effects is one of xanthopsia, yellow color vision. Coming next is amber colored vision, amber color opacity. All right. Obviously, you need to keep also one more thing in mind, that even in glaucoma, there's a lot of frequent changes of refractive indexes, but they are not going to be actually complaining to you, or they are not going to tell you that there's going to be a second vision. All right, the second vision is only because of improvement of the near vision, and that can only occur when there is increase in refractive index, and increase in refractive index can only occur in case of increase in sclerosis of a nucleus. So that is definitely a nuclear cataract that is going to hit your diagnosis, and that is when you're done with the diagnosis. I don't think there's much that can be spoken about nuclear cataract. I think next we're going to get into definitely is your is the senile cortical cataract. Okay. So in carotid cataract, it is in the periphery around here, around here. It's one of the peripheral cataracts. It's the pathology is basically hydration of the lens. There's hydration of the lens, then there's splitting of the lens fibers, okay, splitting of lens fibers, then water vacuoles being formed, water vacuole, okay, and obviously then there's lamellar separation, okay. So these lamella they separate, okay, and when they separate, there's obviously something called as a cuneiform cataract. Amazing. Okay, so what is the first stage? The first stage is lamellar separation, because these are the stages that are actually needed. Second stage is your cuneiform are the wedge shaped ones, okay, the cuneiform cataract, okay, or a cuneiform cataract where radial spokes are seen, okay. And third is your third is something called as an intumescent. Actually, before we go there, let's talk about the immature cataract, or you could remove the immature and put it as intumescent, almost as the same stage. A lot of books write it as the same stage, some write it as a different stage. Intumescent cataract is swelling of the lens, all right. So the swelling of the lens has occurred, and there's going to be removal of the iris shadow. And then you have the mature cataract. Where there is no iris shadow, definitely. There's no complete loss of iris shadow in the intumescent or immature cataract, but definitely gradually, yes, there is loss of your iris shadow. There's basically swelling, okay. It is a dirty grayish lens. So, and your intumescent and then your mature cataract, all right. So mature cataract is your white in color, but your immature cataract is dirty green. Your iris shadow is preserved, iris shadow positive. Your no iris shadow. All right. After mature, you have something called as an hypermature cataract, and hypermature cataract is basically into two parts. One is your Morganian, other is your sclerotic. A Morganian cataract is basically your cataract has become so heavy that it falls into the, okay, your cataract has become your nucleus is out here, your nucleus just dips because all of this cortex is liquefied, so your nucleus dips and it falls down. So this is basically your Morganian cataract. And Morganian cataract is a very important because it can cause phacolytic is leaking of proteins, and it can go and cause glaucoma because it can go and settle in the trabecular meshwork, okay. So let's say this is the iris, and here is your trabecular meshwork, here is your cornea. So they settle out here, they come in and they settle out here, so they can lead to a phacolytic glaucoma. Then we have something called a sclerotic changes. Sclerotic is basically the capsule becomes wrinkled and leathery, and it could directly subluxation of the lens could occur, and very important is that when subluxation occurs, they can go and they can lodge in some other part of the lens, and this is basically called as a phacotopic, okay. Phacotopic glaucoma. And also there's a certain amount of iridodenesis because of the liquefaction of the lens, and because of the wrinkling of the entire lens capsule, okay. So there are basically three types of glaucoma that can occur because of a cataract. One is your phacolytic, one is your phacomorphic, one is your phacotopic. Phacolytic is because of breaking of the proteins and they dispersing into the trabecular meshwork. Phacomorphic is because of the pushing of the iris, all right, and phacotopic is because of the dislocation of the lens. Remember these three, and almost secondary causes of glaucoma almost sorted. After that, after this very important thing that we've spoken about, we must talk about two causes of ectopia lentis. Two causes of ectopia lentis are Marfan syndrome and homocysteine. Homocystinuria. Cysteine is a very important protein. Most of the people think that Marfan syndrome leads to dislocation of the lens in the superior temporal, and homocysteine leads to infero-nasal. Very important point is also given in first aid very well. The amazing mnemonic as well. Superior temporal, infero-nasal. Remember that always. Secondary causes of glaucoma in terms of lenses have also been covered. I think we've also spoken about senile cataract and the three types of ways: phacotopic, phacomorphic, phacolytic glaucoma has also actually quite literally been covered. And there's something called as a posterior subcapsular cataract, again in a senile variant of posterior subcapsular cataract, which is basically something called as a cupuliform cataract. We had cuneiform in your cortical. We have a cupuliform cataract. Again you cannot see it during the day. It's loss of vision. Vision improves in dim light, obviously, and glare is also very much present. And I think certain important anterior subcapsular cataract that we should remember. I said trauma, one. Lightning trauma, not just any trauma. Second is your shield cataract. If you know what a shield cataract is, basically a VKH, vernal character. Certain drugs, gold, amiodarone. Amiodarone is a bloody terrible drug, dude. Can cause literally anything and everything. And angle closure glaucoma, acute angle closure glaucoma. Angle closure glaucoma can actually lead to glaucoma flecken, and glaucoma flecken is usually subcapsular, but chalega मैं इधर बोल देगा कि ठीक है. Someone asks you, so you can obviously always say that acute angle closure glaucoma can also lead to an anterior subcapsular cataract. But definitely a very important thing to note when it comes to glaucoma or angle closure glaucoma is glaucoma flecken as well only. Anterior subcapsular cataract is definitely one thing very important to note. Okay. Lenticular opacity and stuff like that. Vox triad is very important to know. Vox tri is very important to know the difference between all of them. And I think we're done for this day.